Good morning, everyone. I'm Chris Byer, the Associate Director for the Johns Hopkins Center for AIDS Research, and I'm delighted to welcome you to the first event of the fall for the 2018-2019 academic year. This is a bit of a hybrid event today where we're going to start with this symposium on HIV and syphilis. We are going to have, I think, a wonderful bridging speaker in the middle of the day at the lunch. There are very few people who could do an implementation science keynote and a syphilis and HIV keynote, but Patrick Sullivan is one of them. So we're delighted to have him, and I did see him. He's here. He's in the building, putting in a grant today, but will be with us shortly. And we're really, I think, also particularly delighted as we kick off the Syphilis Symposium that our partners from the Baltimore City Health Department and the Assistant Commissioner for Clinical Services, Adena Greenbaum, is here and is gonna kick us off with framing the issues. So that, I think, is the future of the CFAR. We want to be as integrated and helpful and useful to the city and the state and the communities we serve as we possibly can be. So we're really delighted about that. I just want to say briefly the impetus for this Syphilis and HIV Symposium, because I think that will help start off the day. And this really came out of an HPTN protocol that I've served as protocol chair for, HPTN 078, which was an attempt to use deep chain respondent-driven sampling to recruit men in 4 U.S. cities, gay, bisexual, and other men who have sex with men, of all races and ethnicities, and identify men living with HIV and not virally suppressed, and recruit them into a case management intervention that might improve rates of viral suppression in this group. And this is an unusual study for the HPTN because the Prevention Trials Network generally has HIV incidence as their endpoint. This was the only study in the network that was focused entirely on men living with HIV and trying to drive down viral suppression. So it's kind of the other side of the equation from primary prevention, really a secondary prevention approach. In the end, we screened close to 1,400 men, 1,300 men and change, so it was a very large sample, and the cities where we did this work were Boston, Baltimore, Atlanta, Georgia, and Birmingham, Alabama. The good news is that we did find a substantial proportion of men living with HIV who were virally suppressed, so that's great. It was about 80% viral suppression, and that is somewhat what you'd expect because these are all university centers. The bad news is that the HIV prevalence overall in this population was 70%, which is kind of breathtaking. In the respondent-driven sample, so in this you're recruiting men and then asking them to recruit their peers, the prevalence was 50%. And then one of the things that was so striking to us was that among this very large, almost 900 men that we identified living with HIV, about 22% had reactive syphilis serology to both the nonspecific and the treponema-specific tests. So that is really an extraordinary burden. And when we dug into that a little bit more, it turned out that 91% of the men with syphilis were HIV co-infected. So this is a syphilis outbreak that is very much happening in the context of HIV infection. And a substantial proportion of those people both had active syphilis and were not virally suppressed. So that is really an enormous challenge, both for those men's health, but also for, of course, onward transmission of both pathogens. So that was something of a wake-up call for us. I will say that of the 4 cities, for once, Baltimore did not have the highest prevalence. It was rather surprisingly and disturbingly Atlanta, where among the men living with HIV, 31% had syphilis. Which is really quite an extraordinary amount. And when we talked to the staff there, they were not surprised. They all kind of said, yeah, we, this is about what we see in our clinic, that about this very high proportion of men who have sex with men have syphilis infection. So there really is an epidemic. And then many of you will have seen, and I know the STI experts in the room, many of you were at the recent CDC conference. Again, for the fourth year in a row, STI rates increased in the United States. Syphilis is not the most common, but a rate of increase, it had the fastest. So in the last 5 years, there's been a 76% increase in syphilis diagnoses. And that is really, I think, just breathtaking. And again, with those CDC data, we don't have gender and sexual orientation on everybody, but for whom the data are available, 70% of those infections are in men who have sex with men, which is, after all, sometimes gay men like myself, we think that there are a lot of us in this country, but actually we're a small proportion of the population, and to have that large a burden of infection in such a small subgroup really tells you this is a concentrated epidemic of syphilis in men who have sex with men, and particularly in men who have sex with men who are living with HIV. So that is really our challenge, and I think that is why the CFAR felt that we really ought to kick off this new year trying to address this public health problem. We are delighted to have with us to start this day Adena Greenbaum, who, as I mentioned, is the Assistant Commissioner for Clinical Services for the Baltimore City Health Department, and someone who's well known to us and has had a good part of her career and training at Hopkins. We're delighted that the city is so engaged and taking this seriously. And Adena, without further ado, if you're going to set the stage for us and talk about Baltimore, the city we all love. So please join me in welcoming Adena Greenbaum.
Thank you. Hello, good morning. I'm going to provide a brief and fairly simple and I think straightforward overview of the epidemiology of syphilis in Baltimore, and then talk a little bit about a current syphilis outbreak that we're seeing in the city. That's not among MSM, that's among a different population, but I couldn't talk about the current situation of syphilis in Baltimore without mentioning the current outbreak that we're seeing. So first, I'm going to try to cover three main areas. First, the health department's general role in syphilis, what we do day to day in syphilis, then a brief overview of Baltimore syphilis epidemiology, and then recent syphilis activity that we've seen in the city. So I've been asked this question several times, some by members of CFAR, just what is the health department's structure when it comes to both syphilis and HIV, and who does what? So just wanted to take a few minutes to go over that. So we have the health commissioner, who's Dr. Alina Wen, and then I'm one of the assistant health commissioners underneath her, and oversee both clinical services, which are the clinics that the health department has that provide direct services to the people of Baltimore. And the boxes that are highlighted in yellow are those that have some direct activity having to do with syphilis in the health department. So we have our STD and PrEP clinic, our HIV and Hep C clinic, a dental and TB clinic, and our clinical lab, as well as our mobile clinic. And then as of November, I'm also overseeing the HIV and STD prevention activities in the health department. So that includes all of our epi and surveillance for HIV and STDs in the city, our HIV and STD prevention programs, which include our HIV testing programs and coordinating HIV testing among partners in the city, our newly formed PrEP and U=U programming, and our newly formed Hep C program, our HIV and STD field operations, which include our DIS, or our partner services team, which I'll talk a little bit more about, our linkage to care team for HIV and Hep C services, and our outreach team, which does HIV and STD testing throughout the city, and then our newly formed social innovations and community engagement program. We'll talk a little bit about some of these groups, like I said, that are in yellow that work on syphilis in the city. So what are the syphilis prevention and control activities in the city? So first, there's syphilis testing. So we have an outreach team and other partners who do syphilis testing. We have several mobile vans that go out and do testing throughout the city, or we attend health fairs or events that the mayor asks us to attend, or community fairs, or when the community calls and says, hey, can the health department come and do testing at my event? Those are the folks who go out. And then we do have our lab, which runs all the syphilis tests for all of the health department activities, and then some other groups throughout the city utilize our lab as well. And then the health department is notified of all positive syphilis serologies in the city, no matter where those are ordered from, no matter what lab those tests are conducted in. And then I just wanted to mention how there's several, more than these three, but several references in COMAR, which is the Code of Maryland Regulations, which are the regulations that the health department uses to do our work, that reference syphilis. So the ones that I've listed here have to do mostly with reporting, how providers are and labs are obligated to report syphilis cases to the city, and how it's the city's obligation to follow up on those cases and ensure people are in treatment. And then there's other sets of regulations surrounding things, for example, like partner services. So then once we get our labs, once we get all these labs into the health department, every single one of those labs is sorted and gone through, and we use this syphilis reactor grid, which lists the different types of lab results you could have on top, and then the ages going down the side to decide what is done, and based on the level of risk, based on the probability that this is an infectious case versus a non-infectious case of syphilis, that determines what the health department does. So in some cases, nothing is done at all with those labs. It's clear that this is a non-infectious case of syphilis, and that case is considered closed. In some cases, a little bit more work is needed, so that's some administrative work is done within the health department to evaluate, is this probably an infectious case of syphilis that requires further investigation or not. And then in many cases, we can't determine that within the walls of the health department, so we need to send people out and find out more information about the case to make sure that that person has been adequately treated. So in those cases, so all three of these things occur. So first we call the provider and we find out more information about treatment, the reason for the patient's visit, any symptoms they might have had, and any additional locating information for the patient. We call the patient to make sure they're aware of the result, confirm that they were treated, provide further education about syphilis, get information about their symptoms to help with staging of their disease, get information about partners, sexual partners that they have, discuss a risk reduction plan with that patient, make sure that they received HIV testing and other risk reduction counseling such as PrEP, and ask about access to condoms and ask if they would like condoms. And then we call their partners and we use language along the lines of somebody you have had sexual contact with in the past has had a positive test, and inform them that they should get tested for STDs or syphilis or HIV depending on the situation, and help them get tested. And if we can't reach them, we leave referral cards such as this saying an important matter regarding your health has come to our attention. Please come to the clinic. Please contact the health department. So that's just a brief overview of what the health department does every day for syphilis. So now I'll just present some basic syphilis epidemiology. Many of you have studied this much longer than I have, and know nuances of this much more than I have. So feel free to add your comments. So first, this shows the numbers and rates of syphilis cases in Baltimore City from 2000 to 2017. You can see in the blue bars the number of cases, which has fluctuated a little bit throughout the years, and the rates, which have also fluctuated. And then the dark bar at the bottom are the U.S. rates. So you can see the increase in the U.S. rates that we've had over the last few years. It does not reflect the most recent data that was just released by the CDC, but we know that the trend shown here is continuing. And in general, even though that the syphilis rates in the city don't necessarily show that same general increase, what I take away from this is that the rates are just so much higher than the national rates that's really the main takeaway from this. So in general, we see around 200 cases of, this is primary and secondary syphilis, around, give or take, 200 cases of primary and secondary syphilis in the city per year. And then this just shows the number, if you add on the early latent cases, how many do we see for the years that we have data available in the darker blue bars. And around half the cases that we see in general are primary and secondary syphilis, and then around half the cases are early latent cases. So if you're looking at everything, all cases all together, on average between 350 and 400 cases of syphilis each year. So this shows the rates of primary, secondary, and early latent syphilis, comparing those in Baltimore City, again, to those in the United States. So the blue bars are for Baltimore, and the green bars are the rates for the United States. And you can see fairly similar trends for primary, secondary, and early latent in Baltimore. And again, just that the rates are so much higher than the average rates across the United States. So then there's congenital syphilis. Congenital syphilis is quite a large problem in Maryland and in Baltimore. So Maryland currently ranks 5th in the nation as having the highest rates of congenital syphilis nationwide, and a large part of that burden is in Baltimore. So although the numbers themselves are not necessarily high, we typically see around 10 to 12 cases of congenital syphilis a year in Baltimore. Each one of those cases is a sentinel event, and the rates are, again, much higher than what we're seeing across the rest of the country. Then if you look at the numbers of cases by sex, you can see a shift in the late 1990s and early 2000s from it being, at least from where we have data, fairly equal to really a predominance among men, and that has continued over the last 15 years. And then if you look at the number in cases of primary and secondary syphilis by age, here I'm only showing the data for 2017, but we do not in general see a large shift in this over time. We see a majority of cases in the younger population, especially in the 15 to 35 year age groups. And then if you look at the data by age and by sex, the age groups are along the x-axis and the number of cases along the y-axis. You can see the distribution is slightly different. So the blue bars are men and the red bars are for women. And that bump that we see in the younger age groups tend to be more in men. You see a little bit of that in women, but in general, the age distribution for women tends to be a little bit more even throughout the age groups. And then looking by race, so here we're set up a little bit differently with the groups of race across the x-axis, and the years are the different colors, starting in 2012 with the blue and ending in 2017 with the purple. And a majority of cases, of primary and secondary cases in the city are in African Americans, but we are seeing a little bit of shift in that over time. So we are seeing increasing proportion of cases in Caucasians. And then to look a little bit by reported risk and also by gender, to look at the number and percent of cases that are in MSM. This graph shows for 2013 through 2017, the number of cases and the percent of cases in women in the dark purple at the bottom, and then the next lightest purple up top in non-MSM men, and then the lightest purple up top in men who identify MSM as a risk category. MSM is the majority of cases we see in Baltimore are among MSM, and that has remained fairly consistent over time. And then, although not exactly, not looking at HIV co-infection in exactly the same way we discussed earlier, but looking at the number and percent of syphilis cases which are co-infected with HIV in general, but this graph is only among men, so this is only among men. At least half, a little over half of syphilis cases are co-infected with HIV, which are the yellow portion of the bars. So in general, looking at the 2017 demographics, which are fairly consistent over time, although we are seeing some shifts, 50% of cases are among people who are under 30 years old. 73% are African American, 88% of men, and among men, half are HIV infected. So now to shift a little bit to the current syphilis outbreak that we're seeing in the city. I guess the second syphilis outbreak. I would call the first syphilis outbreak just general syphilis that we see in the city, but the second syphilis outbreak. So just to provide a little bit of perspective, in 1997 to 1998 were the highest rates of syphilis that we had seen in Baltimore. At that time, there were around 456 cases, that's of primary and secondary cases, I believe, per year, so around double what we see now, and 28 cases of congenital syphilis. At that time, the Syphilis Elimination Plan Working Group was established as a collaboration between the health department, academic institutions, and various other partners, and implemented several interventions to address this. And by 2002, the rates of syphilis in Baltimore had decreased to the lowest they had been in recent history. However, in 2004, there was an increase, 133% increase in cases when 70 cases were identified in the second quarter of the year. And around that time also was really when the shift to seeing the burden in MSM was identified as well. And I'll show some documentation of that in a moment. And then from 2008 to 2017, we've seen about 160 to 250 cases of primary and secondary syphilis annually, with a rate between 22 and 37.5 per 100,000 population. So it's remained fairly consistent since 2008. This is back in 2003, a provider letter sent out by the health commissioner at the time, Dr. Bailenson, noting that in 2001, there were 7 cases of early syphilis among men with same-sex contact. In 2002, there were 44 cases. So to me, this really showed that the beginning of the of seeing the amount of syphilis and MSM that we're seeing now. And it, of course, has just continued to increase since then. So things were going along just fine at the health department. And then in April, a DIS, or a partner services supervisor, was reviewing cases and said, I'm seeing a lot more cases in white women in Western Baltimore than I'm used to seeing. And this has been, when we took a look back, it looked like that increase had been going on since January. And when we took a look, there were 14 new cases of syphilis among white women in January through April, and many of those reported transactional sex and IV drug use. And this was a high number for us. We felt like this was unusual. So we started some additional outreach and testing, and had our first syphilis Blitz event. So our syphilis Blitz events are our outbreak response event. So this is going above and beyond our routine syphilis work. And we felt like to reach the community that was affected, we really had to go out during times of the day that we were not normally out. And really, we wanted to go out between midnight and 8 a.m. because we felt like that's when these women were out. That's when we were able to get them. We had tried accessing this group of women in the past during other hours and just had not been successful. So our first time, we went out from midnight to 4 a.m. And out of 29 people who were tested that night, most of whom were women, we had 8 positive test results for a prevalence of 28%. And that got our attention. And we were quite nervous. First, we were impressed with the number of people that we got on our outreach van and tested at 4 o'clock in the morning. That was high traffic. That was high traffic for us. Second, we were we were very nervous about this high prevalence we saw, and not just the prevalence itself, but the population that we were seeing. And we were seeing it among commercial sex workers who we knew were having a lot of partners and were concerned about what this meant about spread in the community. And we were also concerned that this was in women of childbearing age, and knowing what we already knew about the level of congenital syphilis in the city, we're concerned about what this meant for congenital syphilis. So we developed a case definition, and that the case definition is currently any person who's diagnosed with syphilis in Baltimore City who reports transactional sex and or injection drug use or their partners from January 1st through the present. And what we're really noticing in this outbreak is not so much an increase in the total numbers of syphilis that we're seeing in the city, although due to how syphilis is investigated and how we count cases, it's really too soon to tell how many cases we have starting in January. We're not going to know that for another few months, but really seeing quite a shift in demographics, and that shift including women, and especially white women of childbearing age. From May through August 6th, from January through August 6th, we have seen 66 cases meeting this case definition of people who were tested in Baltimore. So I'll go into a little bit more detail about those 66 cases and who they are. So these are the positive syphilis cases who report commercial sex work or injection drug use and their partners from January through the beginning of August. 44 or 66% of them are women, and 22 or about a third of them are men. In terms of their age distribution, it is not the same between the women and the men. So in general, the men tend to be a little bit older, and we're seeing a little bit younger women and women across all ages. In terms of racial breakdown, 80% of the women are Black that meet this case definition, and 68% of the men who meet the case definition are white. In terms of what stage syphilis eventually the cases are determined to have. So among the women, 9% primary syphilis, 11% secondary syphilis, and 39% early latent. Among the men, 27% primary, 9% secondary, and 41% early latent. But still with a fair number who have not yet been staged. In terms of identified risk factors for those whom we have data. So for women, 7% report commercial sex work, 24% report injection drug use only, and 56% report both commercial sex work and injection drug use. So for us, this is very much an outbreak very much linked with what we're seeing with drug use in the city as well. In terms of HIV diagnosis, we have seen, I think one of these numbers is off. I believe we've seen 3 cases total of syphilis, 3 cases total of HIV in this population, one of which is a new case. 2 were previously known to have HIV. And among those we are able to confirm at least one dose of penicillin. So 67% of women and 86% of men were able to confirm they've received at least one dose of penicillin. However, there are about a third that were unable, around 20% that were unable to locate and unable to confirm that they've been treated. And then in terms of pregnancy status, we've had 5 women who've been pregnant at the time of the test, and 3 who eventually have gone on to deliver a baby who meets the case definition of congenital syphilis, given what the case definitions of congenital syphilis currently are. We're still evaluating the number of partners that the total 66 cases have, but it's a high number of partners. So on average, the women are reporting 5 to 10 partners a day. Those might not all be unique partners. It's looking like about half are unique partners and half are the same partner, but we're still looking through that. And the men reporting 1 to 5 partners a week. So this is indicates to us that these 66 cases aren't telling us the whole story, that there are a lot of other people, there are a lot of partners out there that we don't yet know about, names that we don't have, people that we don't know if they've been tested, and certainly don't know if they've been treated. In terms of locations, where are the cases being tested and diagnosed? So about half of them are being tested by some activities that the health department runs, whether it's the clinics that we have or other programs, and 20% of those are through our Syphilis Blitz outreach activities, and about a third are in hospitals and EDs, 9% from drug treatment centers, and 3% from other physician offices. This looks at the number of primary and secondary cases by quarter in Baltimore City for 2010 to 2018. So this shows the first 2 quarters at the very end of 2018, the number of cases by men and women, and is beginning to show a little bit for quarter 1 how we might be seeing a little bit increase in the number of cases in women. But again, the cases from quarter 1 are just finishing. Not all of them have been closed. And then this shows a little bit more the distribution of primary and secondary syphilis by age and race, comparing 2017 to 2018. So the gray bars show the averages for sex and race for 2017, and then the pink shows how that's changed in 2018. So you can see at the bottom in women, less than 1% in 2017 of primary and secondary cases were in white women, and so far this year we have 6%. And then this is similar to the graph I showed before of looking at gender and MSM as a risk factor. However, it only looks at the first 2 quarters of each year, from 2013 to 2018, and again is still very preliminary data from 2018, but is showing perhaps an increase in the bottom black line of percent of women making up our cases. So in terms of what we're doing, we have our Syphilis Blitz event. So we are out in the city. Overnight shifts are either from 12 a.m. to 4 a.m. or 4 a.m. to 8 a.m. Currently, we're doing that twice a week. And what we're doing during those Blitz events is different than anything that we've done before, at least recently. So we not only have our testing or our outreach team there conducting the tests, but we also have treatment on site. So we have providers on site who have protocols of who to treat then and there, whether it's somebody with a positive test that we know needs to be treated, or somebody who's presumptively positive who should be treated. And we also have partner services on site to conduct those partner services interviews right then and there. And we choose our locations based on a number of factors, some quantitative, some qualitative, based on testing rates, reported partner meeting places. So when we do those partner interviews, we ask people, where are you meeting your partners? And then conversations with staff and community members about where we should be in the city. And I can't speak highly enough about the teams who are out there in the middle of the night. There's a photo of our van with the lights out in the middle of the night. They're out on street corners talking to people. And then our clinical van, Healthcare on the Spot, which has our providers providing treatment. And then providing some care on the van. In terms of the test results that we've seen from these Syphilis Blitz events, so we've tested 348 people for syphilis and about the same number for HIV, about half of those for chlamydia and gonorrhea. You can see the number of positive test results that we have for each one of those tests, and then the percent positive that we're seeing on Blitz events, and the percent positive that we saw last year during traditional outreach events. And what I would say about these is that although the percentages are fairly similar, if you look at the average percent positive for syphilis and what we normally see during outreach events, it looks similar, but the range that we're seeing at different sites is just very dramatic. So we can see anywhere from 0% up to, I took out some outliers where the sample size was very small, but up to 30-40% in some cases, which remains surprising and concerning. These are some maps showing both our syphilis Blitz events throughout the city and our traditional outreach sites, and the number of new syphilis cases that we've identified at those sites. And then also showing the positivity rate, with the red being the higher positivity rate at those locations. So our continuing activities, we have weekly outbreak activities. We continue our Blitz events twice weekly. We're refining our data collection because, of course, we're finding things that we wish we would have asked, or we're not collecting the data in the right way to analyze, or we really need additional variables. So continuing to refine that, outreaching to various partners, partnering with various healthcare providers and hospitals, especially those that are located in these areas of high rates, and with a strong focus on congenital syphilis. And just wanted to thank the very large team that's involved in all of this work. Thanks.
We probably have time for one or two quick questions. If Adena is willing. Adena, it's great. Are you having staff burnout from these Blitz events? That's a rough work.
Yeah, it's definitely a concern. So we've taken on some additional temp staff to help. And summer is really rough for us because the normal outreach schedule in the summer is so jam-packed with field fairs throughout the city and things like that. So we are approaching that point, but we're hoping that with September coming and we can back off our regular schedule a little bit. We're hoping to avoid that, but it is a concern. I mean, the way we do this is we pay people overtime. So we need to identify funds for paying overtime, which is challenging. And it definitely, but yes, it is definitely a concern.
How do you do your test? What is the mode of testing?
So right now it's conventional blood draw tests that are done. We are exploring doing rapid antibody tests and have developed a protocol with that, and have worked with the PTC here and the state to do that. And I believe the tests have just arrived, so we're going to start piloting that to see how it works. So pregnancy tests are based on important things like bathroom availability. So, it just depends on, so sometimes that's available.
Adena, thank you so much. So we didn't ask the gentleman who asked the question about testing and assays. You're not a plant. That was a spontaneous question, but happily it's a beautiful lead-in to our very own Charlotte Gaydos, who of course I think is known to probably everyone in the audience, and who really is one of the experts in this challenging area of STI diagnostics, point-of-care diagnostics, innovations. And we thought that it was particularly important to have this early on in the session because, of course, we have so many young investigators who are part of the CFAR who would like to include STI measures in their HIV research grants. And so, Charlotte, you've been a mentor to all of us. Welcome. We're delighted to have you. Oh, I should have done that for you. Sorry.
Good morning, everyone, and thank you so much, Dr. Greenbaum, for setting the stage. I'd like to thank all the organizers for inviting me to speak with you all this morning. So, let's see. So here are my disclosures. I work with a lot of diagnostic companies. These are my objectives. We're going to talk about tests, syphilis, HIV. I want to start with a case presentation. This is a 27-year-old man with blurry vision, oral and nasal mucosal lesions, and a skin rash. Who in the audience would have thought immediately of syphilis? Okay, so whatever. But probably not a lot of clinicians. Some might have thought, oh, this is some funny fungus or some mycobacteria. Well, it turned out this was an HIV seropositive man who was co-infected with syphilis. So it is known that they do have a higher rate of atypical forms. He did not manifest with the classical symptoms of the maculopapular rash. Thank you for bringing to our attention, Dr. Greenbaum. Syphilis is still a major health challenge. Some of us, including Anne here, published some articles earlier in STD about variations in types of ocular syphilis. I think it's well accepted that we have a syphilis HIV syndemic, and I want to call your attention to New York City's having the same problem we are. This showed that out of 2,800 men with syphilis over 11,000 person years, 15% acquired HIV. The incidence was higher among MSM, males with secondary compared with primary, and males who were diagnosed with another STD. So not only syphilis and HIV go hand in hand, but also other STIs. I think everyone in this audience knows we have to have two tests, syphilis treponemal and non-treponemal. We do have biological false positives. Even the treponemal test can be falsely reactive. Both tests are imperfect, and there's no perfect test. So we do the best we can. Ordinarily, we used the TPPI and the FDA for our treponemal tests years ago, but in the 80s, we started seeing recombinant syphilis antigens, and so there appeared on the market a whole bunch of EIAs, CIAs, MFIs, and these have become commercially available. Laboratories love them. Clinicians hate them because the RPR is very labor intensive, as is the FTA. These tests you can put 100 on and run them all at once. So this eventually led to the CDC saying, let's use a reverse algorithm, and instead of doing the RPR first, let's do the treponemal test first. So here's names of all of the different ones that are on the market. And they're all pretty good as far as a treponemal test. I want to talk a little bit later on about the point of care tests that can rapidly present a diagnosis in 10 or 20 minutes. Advantages, disadvantages, again, they both have the treponemal tests may detect old untreated syphilis, so it has to be confirmed. We really have less experience nationwide. This is not so much true anymore, but people are becoming more familiar with how the reverse algorithm works. And they may be less sensitive. This is from Anne Rampalo, so she can ask her if this is really true. But anyway, our traditional algorithm was that we did the RPR first, and then if it's positive, we confirmed it with another treponemal test. Then CDC decided that we should do the reverse sequence. Not everyone in the world has adopted this. Many people are still doing the traditional, and that's to do the multiplex, really fast EIA test first, or a point of care test, which can be done in the field, and then do the RPR to confirm it, and do the quantitative RPR to follow the titers. If you get down and your TPPA doesn't confirm, it means that you could have passed, or it could be still present and it just hasn't converted yet. So if the person really thinks that the syphilis is likely, then they should repeat the RPR in a few weeks. But exciting, there's now an automated RPR syphilis testing machine on the market, which is FDA cleared. It's available. I found this a couple of years ago, but now last week at the CDC conference, there was a group who had evaluated this compared to the RPR, and there were a couple of disagreements, but it looked really good in its results. So this might be an answer. So you get digital results. The person that reported it said they changed their staffing level from 4 people to 1. So anyway, stay tuned. This is an article we've evaluated 6 of those automated treponemal antibody tests. Basically, they all were pretty good. The first column is sensitivity, then specificity, and then compared to the FDA absorbed test, the last column pretty much 100%. So they're all pretty good, and they save the laboratorians a lot of time and effort. However, there's only one point-of-care test that's FDA cleared in the United States. The nice thing is that this is also CLIA waived. Basically, it takes 10 minutes, can be done at room temperature. You either get a negative with one control line, or you get a positive with two lines there, or you get an invalid if you get no lines, or if you get a test line but you don't get the control. So you have to look for the control. I want to point out one that we have looked at. It's not FDA cleared yet, but it's been evaluated ad nauseum. The company used to be Standard Diagnostics. They were bought by Alere, and now they're bought by Abbott. So I think we'll see more for this test. It takes 15 minutes. Klausner and his group have evaluated some of these rapid tests for syphilis. They're not all what they're cracked up to be with the point of care, sadly. So this is an analysis of 33 studies. The sensitivity ranged from 75 to 83 for whole blood and 75 to 92 for serum. Specificity was pretty good. I just want to remind all the clinicians that you get a positive test. So clinicians are interested in the positive predictive value of a test, not the sensitivity, which we in the laboratory are interested in. But you can see here that if you have a low prevalence population and you get a positive test, your positive predictive value is like 20%. If you're in a high prevalence, like Baltimore, and you get a positive test, your positive predictive value can be a bit higher. So just a little nuance to when you get positive tests. So we've reviewed some of these point-of-care diagnostics a couple of years ago, and basically they're not perfect, but sometimes it's better than nothing if you don't have any tests. So this Abbott Determine can range anywhere from 59 to 100, depending on the publication. And then here's the Trinity Health Check, which is we found that to have the best probably of all the sensitivity. So I guess that's good that that's FDA cleared. So what we would love is, can we have a point-of-care test that combines the treponemal and the non-treponemal? Well, stay tuned. ChemBio's been working on one with CDC for years. And it's been evaluated in publications. It's not FDA cleared yet. The treponemal test is really good. The RPR, it'll pick up the higher titers, but not the lower. So here's an evaluation by Castro et al. That compared this little point of care, they call it confirm and treat, test and confirm, screen and confirm. 98% sensitivity and good specificity compared to RPR. They compared it to TPHA, and they compared it to FTA. So we're hopeful. The best evaluation I've seen in the literature of this dual treponemal, non-treponemal test was in CID a couple of years ago from Australia. And the sensitivity, they pulled hundreds of sera out of their freezers, and they knew if they were primary, secondary, whatever. And so their sensitivity for the treponemal 1 was 89, specificity was 99. Their sensitivity of this ChemBio test for non-treponemal compared to the reference RPR was 94. Specificity wasn't as great as one would have liked, but here's a bar graph showing in the dark lines their T2, which is their non-treponemal test result on the little point-of-care test, and the white bars show the actual RPR that they compared it to. This was 527 patients, so not bad. I was very pleased to see this, and I hope they proceed with this test. I'm going to skip this. Basically, they got 80 for the big study with over 1,000 people. They got 89% sensitivity and 94% sensitivity for the second line. So there's a whole bunch of new tests on the market. This is from an article in Lancet Infectious Diseases last year. And you can see that there are a whole bunch of new ones on the market, M-chip, and this biolytical one, and the multiplo. But I want to call attention to this one, the DPPP syphilis test, and it's a combo test. But we'll talk about that. So that leads me into, can we have a point-of-care test that tests for syphilis and HIV? Yes, we can. So this is the one that ChemBio, we just finished the clinical trials a few months ago. It's at the FDA. I spoke to Tom Ippolito last week, and he said they're dialoguing back and forth. So we may, in the next couple months, see that it will be FDA cleared. So he couldn't give me any information on the whole, but we have a sneak peek. We participated in the trial here. We enrolled 300 patients in the Baltimore City Health Department, and we looked at fingerstick and whole blood and plasma. And out of those, we had, this is the HIV data, really good, 100% data for picking up the HIV cases, and specificity was good. This is the syphilis data, picked up all with the fingerstick blood. And the nice thing about this test is it has a reader, so you don't have to worry about whether or not the reader is reading in the dark in the van, or whether they may be colorblind or see a faint pink line or a dark pink line. That's a lot of problems with a lot of point-of-care tests. So this one has a little reader, and they actually delayed the trials by 6 months to continue developing this reader, and you just set it right on the thing, and the reader tells you the answer. So Jeff and our lab presented this at the Clinical Virology Symposium. So we were pleased that they allowed us to present this early data. So we also had evaluated the SD BioLine, which is now a Lear, which is now Abbott, and so I think we may see clearance of this coming. But this again uses all sample types, and it's room temperature. So here's Jeff's evaluation. Was interesting across the top is what the answer was compared to the RPR and to the TPPA. So pretty good sensitivity and specificity. And what was really interesting, and I don't want to dwell on this too much, but when he was looking at the data, he said, what if we did the RPR first and did the old algorithm? We would end up confirming by TPA, and we had 13 positives out of 381 samples. But what if we did the reverse algorithm? And this was quite a dilemma. If you did the TPPA first and then confirmed with the RPR, we ended up with 22 positives. So this really is concerning. I don't know really, I think we need to look more research on this. So this is on that duo test by the one by Lear. We had really good agreement for HIV. There weren't many that were positive. This was the serum bank that we had in our freezers. But basically, we finally, after doing an adjudication of two discrepants, we came out with a sensitivity for the HIV sensitivity and specificity of 100%. There are others on the market. This is a Canadian group. I think it's not quite as good as either the ones that I've spoken to, according to my friend Yeti, who looks at all these point-of-care tests at CDC. But what was interesting to me was people are always saying, well, how do we know if it's early or repeat syphilis? So this paper looked at the different immune response with IL-10 was different, but they looked at 9,000 with initial syphilis and 55 repeaters, and they found that at baseline, if they were an initial syphilis, they were more likely to be symptomatic and higher levels of interleukin-10, which I thought was quite interesting. And then the baseline median RPR titers were higher, and then repeaters were less likely than those with initial infections to serorevert to a negative and to be serofast. So it's always a case where you can't just look at the data from the test. You have to evaluate the patient. So anyway, point-of-care tests are getting better. We need more research. The automated are very acceptable for screening with the treponemal. And you still have to look at the patient's clinical and treatment history. So HIV, we have a lot of tests that are cleared. The newest one that I want to talk about is the Lear one here. And I owe a lot of these slides to my friend Michelle Owen at CDC. But this is the one that we are using for our mail-in syphilis tests. It takes 20 minutes. You can store it at room temperature, long shelf life. It's CLIA waived for whole blood. And the next thing about it is it not only detects the antibody, it detects the P24 antigen. So the Genius has been put out there to replace the multi-spot, because if you do a treponemal test, then you need to confirm it with another assay, and or another. You need to confirm it with a second HIV assay. And so this kind of looks like a Western blot, but we don't have much data on it yet. But people at CDC seem to think a lot of it. These are some of the big robots that I mentioned. You can see why people would want to do many at a time on the machine than to do one test. But all of the fourth generations now do P24 and also the antibody, and distinguish between 1 and 2. However, I saw an article last week and said that CDC is going to do away with the word generation. You're not going to be fourth or third or second. They're done with that. So this is the Bioplex, which they seem to like a lot. Here, the Alere company has gone even a little further, and so they're doing a quantitative point-of-care test. And you get your results in 50 minutes, and they have a little cartridge that they put it in, and then they put it in this little machine, and they can store the data. It's very lightweight. It can be done with a battery. So looking forward to see if they ever get clearance. For viral load now, the Hologic Panther system, we're using this in Tom Quinn's HIV lab right now, that you can use this for the viral load. They say don't use it for blood bank and don't use it for diagnosing HIV, but if you want the viral load, this is a nice assay. Cepheid has come out with an HIV viral load also, and they can use batteries, and you can do 1 at a time or 4 at a time or 80 at a time. But this little plastic assay machine, which is probably maybe only cost $1,000 instead of $60,000, that is coming. They're working on it for STIs and HIV. So, in fact, one of their administrators told me once that they think that next to your Keurig in your kitchen, eventually everyone will have these, and you can just test yourself every morning for what you want to test for. But another interesting one that's a point of care for all STIs and for a viral load for PCR is the LIOT by Roche, and LIOT stands for Lab in a Tube. It's a little tube, almost looks like a toothbrush, and you put the thing in, you put it in the machine, and lo and behold, you get your answer in either 30 or 60 minutes, depending on what you're testing. So the algorithm, it continues. CDC is going to come out sometime soon with a new algorithm. I think they're going to recommend this Genius to be the second test that could quickly confirm the first test. So stay tuned. So I think this is kind of what they're thinking about, that you have your first test here, which could be something like the Bioplex, and then they would confirm with the Genius. And then you can have all different combinations of HIV 1 and 2. And if it second doesn't confirm the first test, then you might want to end up doing a viral load to see an acute. So it's better to use some point-of-care tests than no test, because you then can try to figure out once you have a positive test. But both the clinician and the patient need to be aware of the limitations. And we all know that oral fluid's going to miss some, but what we don't have is any way to diagnose these people here in the eclipse period, maybe someday. So again, old official recommendations by CDC. We're getting better. Their tests are evolving, and they will be sending out a new algorithm. I don't know when we get more data. But again, message for the tester and for the patient: no test is perfect. CDC has lots of guidelines out that you can look at, as does the APHL. And so all diagnostic tests, we want to do a sensitive initial test and then confirm by highly specific tests. So you can use this with combinations: 2 point of care, 2 laboratory, any combination. Anyway. But I want to just end with 2 little comments about self-testing. This is a study that looked at 200 patients to see if they could do their self-test. And they also then mocked up tests and to see if they could identify them. And they did pretty well, 97, 94% when it was mocked up with a contrived. I'm going to skip this and for time, but basically it was using self-testing here too, showing that there were some differences between tests. But just to end with, we have I Want the Kit here for STDs in Baltimore, but we now have a study, which is consent given online for doing an at-home or shore HIV test. And we introduced this a while back. Someone can, if they live in the greater Baltimore area, can request a kit. We send it home for free. We looked at to see what type of person was ordering and using the test, and what could be a predictor of usage. So this is what it looks like on the thing. You can say, yes, I'm interested. No, thank you. I want the kit, STD kit. Instructions are in the kit and online. Basically, we lost a lot of people who said they were interested because the IRB made us talk to them, and then we sent them a kit. But they had to go back online, sign the consent, and then they had to collect and do the test. And we don't know if they all reported or they just did the test and thought, oh, I'm negative, I'm done with this. But we did have some that went back on and completed the test. So 1,400 people accessed the website for whatever reason. 23 said, yeah, I'm interested. We were able to speak to 72% of them, and 90% of these did go back on and got a kit. We only ended up so far with about 160 people. None have been positive. One person reported a week positive. You have to say, my test looks like this, and then the next thing is to interpret the test. So they reported it looked like a week positive, but they interpreted it as negative. So, but we have an arrangement, which is why we're in the metropolitan area, that they can eventually get into clinic. But the ones who ordered the test and did it and reported were female, African American. They had a score. We have a score on the website from 0 to 10. They had higher scores, so they were at higher risk. They were mostly 25 to 29. They were not Hispanic. And what was interesting to me was that more people had used the website before, so they were familiar with the website and how it worked. Basically, they said the test was easy on their questionnaire. They trusted the result very much. They'd recommend it to a friend. They'd use it again. And they preferred self-testing. Obviously, they did it, so some bias there. Anyway, some limitation, basically, but our aim was an acceptability thing to see if people would do it, and they will. I'm going to just end with Yo Shang Shea in the emergency department says, 50% of the people in our ED who are offered an HIV test, and everyone's offered an HIV test, it's opt-out, 50% say, no thank you, and we call these people decliners. So we did a randomization study to randomize 100 people to say, well, you don't want an HIV test today, but how would you like to take one of these kits home and do it yourself? Or they were randomized to say, you're in the control group, here's a piece of paper showing where you can get an HIV test for free in the community. Bottom line is giving the kit to take home increased testing 88% with an odds ratio of 9.4. They were female, about 40 years, mostly white. 43% had not tested in the last year, 19% had never tested, and 40% they said they didn't perceive themselves as being at risk. So this is published in STI in June, but it seemed to, the whole privacy confidentiality thing I think seems to work. So I'm going to end with thanking all the people in my lab who really do all of the work. So thanks.
Do we have maybe one short question for Charlotte, or? Okay, admirable clarity. So our next speaker is Jacky Jennings, who's an associate professor of pediatrics, runs the Center for Child and Community Health Research. Did I get that right? And who's done, as many know, also, of course, has a joint appointment in the Bloomberg School and has done a great deal of work on social networks, on geospatial epidemiology and mapping, and has done a lot of work in the syphilis and HIV space. So, Jacky, over to you.
Thank you so much, and thank you to the organizers, for organizing this lovely forum to bring to light some of these incredibly difficult issues, but certainly that we're looking to make inroads in. And then I also want to start with my acknowledgments, because I couldn't do the work I do without a whole slew of incredibly talented people and partnerships across the city. So this is certainly a village, and it takes a village. So I'm going to talk today a little bit about, I'll just touch on, so Adena did a beautiful job of covering the epidemiology. I'll touch on a couple of those just to get us started. Then I'm going to interweave a little bit of network work that's going on in other places, but also weave that in with some of the work we've been doing here locally in Baltimore City. And then talk about some of the promises of intervention, some of the work that's already going on, and really with an eye towards, we've been working for a long time in collaboration with the Baltimore City Health Department and trying to move evidence really into real program, to move it and make it work and evaluate whether it's working, and with the interest of sort of making a difference today. So hopefully I'll be able to accomplish all that. What I won't talk about today is some of the really interesting work in phylogenetics that's coming out. And locally, this seems to be moving on its own, but we'll get that. Locally, there's some work, for example, that Errol Fields is doing with a CFAR supplement that's starting, and with Kate Gabrowski, Oliver Leyendecker, and Joel Wertheim, and we're starting to see some very interesting results out of that. Matthew Hamill, who's in the audience, was recently funded to do a syphilis phylogenetic study along with Anne and Khalil, and also Kate, and so we should start to see some interesting work on that. And of course there's Eric Voltz across the pond is doing some lovely phylogenetic work actually with gonorrhea, but I won't talk about all that exciting work today. So as you've heard today already, and as we heard last week at the STD Prevention Conference, STIs in general are on the rise. There were nearly 2.3 million cases of chlamydia, gonorrhea, and syphilis in the US in 2017. And syphilis specifically increased by 76%. And the highest rates we've seen both across the nation but also locally are among Black, gay, bisexual, and other men who have sex with men. In Baltimore, Maryland, again, as you saw Dr. Greenbaum present, we have one of the most severe syphilis epidemics. You know, our rates are just sort of a frame shift higher than other places across the nation. And particularly among MSM with a co-occurring HIV epidemic. In 2015, 76% of primary and secondary syphilis cases were among MSM. These were also individuals co-infected with HIV. And that's some lovely work that Christina published in STDs in 2018. So this echoes one of the slides that Dr. Greenbaum showed, and it shows primary and secondary syphilis in Baltimore City from 2013 to 2016. Green shows women, and these, of course, are only with individuals who had known risk factors identified. So women are in green, men who report having sex with women in blue, and men who report having sex with men in red. You can see across the board, men who have sex with men have higher numbers of cases, and in 2017 there were a total of 135 cases. And thank you to Cesar Pena from the Maryland Department of Health for this slide, this information. So there is an urgent need. This underscores the racial disparities in number of new syphilis infections demonstrate that our current prevention strategies are not effective, and we have a lot of work still to do. The fact that we have congenital syphilis cases, as Gail mentioned last week, and many of us wholeheartedly agree, it really any congenital syphilis case represents a failure of our collective system, and just a travesty. So it underscores the urgent need to prioritize syphilis and HIV control strategies, and particularly among MSM at high risk for transmission and acquisition. So let's talk a little bit about strategies. Strategies are most effective if implemented at the right time, in the right place or space, and we'll talk a little bit more about place-space, which has been a focus of our group's work for a long time, and with the most important populations. And network interventions, and specifically sex partner meeting venues and social meeting venues, may be important locales, specifically to access MSM and implement control strategies. Charlotte showed some work out of New York by Preeti and her group. We've also done some work here in Baltimore looking similarly, and this was focused really on the intervention of PrEP. This work was done by Carla Tilchin, who's in the audience, we found that 1 in 10 STI diagnoses among MSM, so this was a retrospective cohort of surveillance data including about 1,542 individuals, and we found that 1 in 10 STI diagnoses among MSM and 1 in 50 STI diagnoses among non-MSM were followed by an HIV diagnosis within 2 years. So again, just a travesty. And what we were looking to do is identify, biomarkers to identify eligible individuals for PrEP. And then among MSM, a syphilis or a gonorrhea diagnosis. I can't underscore the importance of gonorrhea as well. We're going to talk a lot about syphilis, but we need to also talk about gonorrhea. It was associated with a 4- or 5-fold increase, respectively, in HIV incidence. And among non-MSM with gonorrhea, a repeat versus 1 diagnosis with syphilis or gonorrhea was associated with an almost 3.5 times higher incidence. So this is work from, so John Schneider, just at the STD Prevention Conference as a part of our Network Methods Symposium, presented this work and also the next slide work. This comes from his work in a partnership with Fujimoto. And what they were doing, this is a study of 365 young Black MSM ages 16 to 29 years of age in Chicago and in Houston. And this is from 2014 to 2016. And what you see here depicted on the left is Houston and a network diagram of sexual contacts, and on the right, Chicago. You see the links, their specific ties, and those have specific qualities. Those aren't so important about what I'm going to talk about today, but this is a lovely article, you can look it up. But what they found, which was interesting, was that syphilis only and HIV co-infection were driven by network phenomena, not individual level attributes and behaviors. And this is probably not a surprise. I see lots of nodding heads. Not a surprise to our group, but syphilis only cases were associated with a higher number of social venues attended. And syphilis and HIV co-infected cases were associated with having a network members who were co-infected or HIV infected within one social network. This is also work that this group has been doing. This is specifically in the UConnect study in Chicago, also among young Black MSM from 2015 to 2016, a group of 618. And here this is really, their approach is really interesting. So they were looking to investigate how links to local places shape access. So they were thinking about interventions and how these local places shape access to information and exposure to health-seeking behavior. And this was a longitudinal study with respondent-driven sampling. And their results showed that young Black MSM's positions within Chicago's venue network, and so let me orient you a little bit to this because it took me a little while to orient myself. So the nodes here are individuals. So, and the green, so there are 3 clusters depicted here. The green is what they call a gay enclave cluster, community cluster. The yellow is what they call a bridge community cluster. And the black then is what they call a Black community cluster. And then they also collected information on social venues. I have just shown here where there were 3 club bars, 1, 2, and 3, but then there are other venues, there were bathhouses, other venues also collected. And the results showed that young Black MSM's positions within the venue network shape the types of health-related services they access, net of demographic, structural, and community covariates. So men with affiliations that were linked to the city's gay enclave were most likely to know about PrEP, while men with affiliations that were predominantly in the Black community demonstrated improved HIV treatment outcomes. And they concluded, that outreach engaging MSM beyond the venues and in enclaves was necessary. So I thought this was a really interesting intersection with venues and community clusters, and really speaks to some of the work that we've been doing locally. So let's talk a little bit about social and sex partner meeting venues. An effective strategy for accessing areas, I would argue, areas of the transmission network that are important and critical for disrupting transmission is to focus outreach efforts on social and sex partner meeting venues. And these are places, venues, social or sex partner meeting, are places where individuals congregate. They may be informal or formal. You see on the left some logos from some of those sites may be familiar to you. Jacked, Grindr, Adam for Adam, but then and those are online sites. There's also Grand Central here in Baltimore City, a club bar. And the idea is that these places may attract individuals with transmissible infection, so that venues themselves and the networks within them may have a force of infectivity, to channel some earlier terms that have been used in the field. And they may also create opportunities for interconnectedness. So we know the structure of networks is really important, but that interconnectedness that then perpetuates incident infection. And what I'm going to also argue is that it's not just the sexual networks within, but actually the connectedness between venues themselves as well. And so these venues and the clusters of venues may be important places for control activities. And we started some of this work way back with the syphilis elimination program and the plan that Adena talked about back in the late 1990s, when we had a large heterosexual syphilis epidemic. And at that time, we added to the partner services interview locally questions about so the importance of contact tracing, right? What sex partners did you have in the last 3 months? But also, where did you meet sex partners in the last 3 months? Knowing that we cannot always identify the full sexual network, but that places may actually represent really important. So it's no surprise to all of us, this is just a little note, that numbers of social media users are growing rapidly, and the expectation is globally there will be 3 billion users in the world. The US, of course, has a high numbers of social media users, so this represents an important new venue to better understand. In 2016, 81% of the US population had a social media profile, and multiple studies have shown use of social media by groups like MSM to be very, very high. So one means to identify potentially epidemiologically significant venues is to utilize a variation on sexual network analyses. Traditional sexual network analyses, in general, it's a tool used to identify important individuals and connections within individuals in that network. And these analyses, again, as many experts in the room know and have conducted, can identify key individuals or central individuals that are essential to the transmission of STIs and HIV. Compared to traditional sexual networks, however, the sexual network analysis of venues, which is often called sexual affiliation network analysis, can reveal important venues. I'm sorry, I don't know why these slides are moving by themselves. Can reveal important venues that are essential to transmission. Importantly, it's an indirect source of data on sexual networks. It doesn't require tracing each direct contact of an individual. It may reveal places where important clusters of sexual networks are occurring. And it may be less resource intensive to obtain, and there may be fewer biases. So asking somebody about where they met sex partners is different than asking about the last sex partners in the last 3 months. And we know from the field that often we get, I don't know who my sex partner was, or it was anonymous, or I don't know the full name, and then it's very difficult to contact the individual. So a little concrete explanation. So sexual networks, we build often from the left, a type of question, who did you have sex with in the last 3 months? And the index is in red, and the two blue individuals are the sex partners. And in contrast, a venue network, we build from a question like, where did you meet your sex partners in the past 3 months? The two red individuals are both telling us that they met at Grand Central, and that's the green venue. So locally, we've done some work in this area with venue affiliation networks of syphilis and or newly HIV diagnosed MSM during a local MSM syphilis epidemic. And our objectives were to describe and quantify the network structure and connectivity of the venues, to examine the overlap in syphilis and HIV transmission networks. So we were doing discovery in particular to better understand, was this the same transmission networks with HIV, or were we seeing different groups transmitting syphilis? Was it really an overlap, and could we quantify that overlap of transmission networks? And then in a sub-analysis to explore temporal changes in the venue network structure, because we know network structures are super important, from 2012 to 2016. The data that we employed were public health surveillance data from 544 MSM diagnosed with syphilis and or HIV and reporting a sex partner meeting venue from 2012 to 2017. And we generated venue affiliation network graphs and whole network structure using UCINet. These are the characteristics of the MSM. And they were 37% were less than 25 years of age, 62% reported Black or African American, 69% had greater than or equal to one partner in the past 12 months, 3% reported injection drug use, 5% commercial sex work, and then 66% were infected initially with syphilis only, 27% with HIV only, and 7% with a co-infection. So then what we did was we generated affiliation networks of these individuals. So what you see, the red circles are individuals that were infected with syphilis only. The blue circles are individuals infected with HIV only. The black are those infected with both syphilis and HIV. And then there are venues depicted in the squares in gray. So here we go. So in other words, this venue, for example, has all three, both syphilis only infection, HIV only infection, and co-infection. And already you can sort of see emerging, it's a highly central venue. Many, many people are reporting this venue. We could also visually pick out several others. And then there are other venues that are also reported but have less frequency of reporting. So this represented, again, 544 individuals reporting on 146 unique sex partner meeting places. Our next step was then to just include individuals reporting more than one sex partner meeting place. And this represented 55 unique venues. And this is the affiliation network of those individuals. And here 16% were syphilis only, 7% were HIV only, and 76% were both co-infected with syphilis and HIV. And you can see that very clearly visually about the co-infection, but then you can also see these individuals that are just syphilis infected, for example. And these unique sex partner meeting venues, these 55, 47% were internet-based sites, 20% were bars or clubs, 15% were street parks or neighborhoods, and then there were a smattering of others. So then we did some network centrality metrics to better understand the positions of these venues. And what emerged was a tightly connected cluster of 5 meeting venues, which represented 59 or almost 60% of all the reports. And these 5 places, 4 of them were online, and 1 of them was a physical space. Again, were highly connected to one another. And they had the highest degree centrality, which means they connected the most number of venues, and the highest betweenness centrality, so in other words, the shortest path between venues not directly connected. So really, very small number starts emerging of potential access points. And then what we did was we compared the networks in 2012 to 2016, and what we found, so what you see on top is the 2012 network, and then the 2016 network. And comparing these two networks, the density of the network increased over this time period by almost 24%, the compactness of the network increased by 16%, and the percent of venues in the main network component nominated by a co-infected MSM increased by 17%. And you can even visually see that change in the color from the top to the bottom. So in conclusion of that work, it suggests that venue affiliation graphs of syphilis and/or infected MSM suggest an incredibly high overlap in transmission networks, that there are 5 highly central venues that emerged, and that these venues may represent an optimal set for tailored interventions. I mean, really 60% of reports were identifying these venues as highly central. So let's talk a little bit about network interventions. This discovery work can, of course, inform network interventions. And this comes from Tom Valence's Science article in 2012, and talks about first defining a network intervention, any change in a program that uses network data to define groups, select change agents, affect network structure, or assist behavior change implementation. And again, there are some experts in the room, David as just one who has done these kind of network interventions. And then there are 4 general types: change agents, to identify key individuals who are opinion leaders, key players or positional bridges. There's another kind, segmentation, key subgroups and their key leaders. Induction, where you recruit subnetworks by word of mouth, and many of us are familiar with respondent-driven sampling, snowball sampling. And then a 4th, which I think we use less in public health, but I think may represent an interesting scenario, and we've been thinking about it in terms of bridging venues. So what if we took out a bridging venue, if we could do that? But this is, so the alteration is, in bioterrorism, this comes up a lot, right? How can you take out a cell from a bioterrorist network and disrupt that whole network, right? So maybe we need to think a little more like, but anyway. Yeah, I'll be careful there. So I'd just like to highlight, I'm not going to talk deeply about this because we can look forward to lovely results. Errol Fields is doing some work, network intervention called Safe Spaces and Places Study. He's funded by a CDC MARI project. And this is using venue-based targeting to access young Black MSM to provide PrEP. And he has been working, again, with our center and in partnership with the Baltimore City Health Department to identify high-risk sex partner meeting venues connected by ongoing HIV transmission networks. So he's using this data that we presented to then go use a mobile van and see if we can recruit individuals online to come in for testing. And a sneak peek, unfortunately, he's finding very high numbers of cases and prevalence, but it's an exciting new potential, promising potential for an intervention, and really a new way to access individuals who may be doing spending a lot of time online. And then I stumbled on in literature as I was preparing this talk, and particularly because I'm often thinking about how to bring evidence into practice, and I also happen to teach the outbreak investigation team, so I love outbreak investigation course with Dr. Taha. But this was an interesting analysis or work that was done, public health work that was done with an outbreak of syphilis in Ottawa, Ontario. This happened from January 2009 to 2010. There were 72 cases of syphilis at the time. And what they did in the course of their regular public health work was do a little bit of an intervention, an enhanced intervention. And the intervention was that they did their standard contact tracing, asking about sexual partners. But then with recent infected individuals, they did an enhanced social network questionnaire where they also elicited social network contacts and venues. And they were able to do those interviews among 17 or 89% of the 19 recent. And so let me just show you some of what the yield from some of this. So this represents just the sexual contacts named. And here, only 155 cases and contacts were linked by nominating sexual partners. There were a total of 55 components ranging from 1 to 19. So often we look at the largest component, which in this case was 19 individuals, as being an important indicator of networks. And of the 19 infectious syphilis cases co-infected with HIV, 63% were in small components of 1 or 2 cases or contacts. Here's where then they added in the enhanced social network interview and the sex partner meeting places. The social and sex partner meeting places. So the 17 enhanced surveillance respondents reported 42 social venues, and the new information helped to link 18 cases and 40 contacts, representing almost 40% of the outbreak population, and connecting many of the what had previously been single individuals and dyads. And now the network consisted of 45 components instead of the 55, right? So we had a diminishing because there were more connections now. And the largest component went from 19 to 95. So an extraordinary change by this, what I would call a relatively small, very low-tech intervention. And the most frequently reported venue, this one over here, was a bathhouse. And it was named by 6 or 35% of respondents. And this was followed by an internet site, a popular gay internet site, which was the second most frequently reported. So really some interesting work. Here's the 2 large components. So this is where it started in the 19, and then, just expanded incredibly. So kind of some interesting practitioner work. So, all contagions are complex. Nothing spreads in a simple manner. And Tom Valente recently sort of ask us all, as we study both diffusion and contagion, let's commit to understanding which network mechanisms are at work and attempt to assess infectiousness and susceptibility. So some final thoughts: infectious diseases and non-infectious work through networks, social, digital, sexual, molecular. Networks are fundamental to transmission and are likely more important than individual characteristics in driving onward syphilis and HIV transmission networks. And I think we really haven't harnessed the full power of social and sexual venues to better conduct our interventions. Network analyses and interventions for HIV and syphilis are intuitive and they make sense. An implementation that utilizes network interventions is key. And then John Schneider will remind us, and I think there's a lot of work emerging that we should be thinking, and Anne Rompalo, in fact, did some work early on in this, including both social and sex partners when you ask individuals about their contacts. And this may help us to get ahead of the epidemic, decrease stigma, and increase coverage. So then just a shameless plug for a new syphilis study with many colleagues in the room. This is the UShine study, Understanding Sexual Health in Networks. We're in the field right now. This is a 3-year funded project from the CDC. And we're looking to better understand transmission of HIV and syphilis in the field. This is in partnership with the Baltimore City Health Department. And we're very excited to be doing the work. So shameless plug. Thank you very much.
Well, thanks so much. Yeah, quick.
A quick question. Jacky, is there any difference in terms of ability to complete network analysis in persons that are purely using digital means to do social networking? In other words, I'm wondering if there's more reticence on the part of the people, or more desire to be anonymous than there would be if it was someplace like Grand Central, where people might
be anonymous. Let me
be less likely to want to identify partners. I'm sorry.
Yeah. So I think we're always challenged with individuals nominating partners, and I think there's lots of biases about why somebody may or may not, and which partners are they willing to nominate or not. And I think that crosses all different groups and all. Okay. So I think actually bringing in the power and actually as an access point of a social or sexual meeting venue changes that a lot, where I may very quickly say, oh yeah, sure, I went to Wit and Wisdom last night with, but I might not tell you who I went with, and I went to, but I might not tell you who I went with or what I did.
Last question, Charlotte. Anne, I should say. Here you go. It's you. You get the mic.
Oh, no. So, I don't want the mic. So
Okay.
There's a natural. Yes. Oh. So there's a natural experiment going on, like the paradox
Yes.
and all these
Oh, yes.
eagle.
This is
They're
a
all
fascinating
closed.
issue.
So the question is, are you capturing that and where are they moving? And then there's two parts.
Fascinating issue, right?
Yes.
Go ahead.
And then if
Question.
say like I meet my partner on Grindr,
Yeah.
do you ask me then where we actually met?
So Brenda Desai is in the room. Oh, I'm going to call you out for a minute. Oh no, she just left maybe. But so she's a current student here in the Epi department. I share the advising with David Celentano, and we are working with NIDA on the Bayview campus to conduct an ecologic momentary assessment study to better understand what we've been talking for a while is what is that journey from online to a physical place and to maybe having sex with somebody. What is that journey? What do we still need to understand about that journey? And we're nesting that within the YouShine study, but we can look forward to that as well. There's a lot of questions that remain about that. And partly, again, we always think about it as an eye towards interventions. So if people are still going to physical places, then it's okay to keep doing testing at physical places that the city health department is. But if not, if they're going then to other places that are less accessible, the online interventions are so important. So I think we have a lot to learn still about it. Yes?
One follow-up. if I do Grindr in the bar.
Well, so that's geosocial networking apps. Again, Errol Fields is super interested, and I think this is a fascinating piece, and it also brings to light still the importance of geography. So many people are using geosocial networking apps in place, and they're in fact in a bar, and they're saying, who can I meet in this bar? And it's an easy way to meet somebody locally, or they're saying within a 1 mile radius. So there's still a geography, and many of you know I've been in the geography world for a while, so I think that's an exciting intersection as well.
And it makes gay bars a lot more boring because everybody's on their screen. So we've come to the break time. We're going to shorten the break by 2 minutes so we can start back at 1:45. And please do come back and join us because we're going to have Khalil Ghanem. We're greatly looking forward to speaking. So 8 minutes break, and there's coffee and stuff in the back. So please help yourself.